like to talk a little bit more, Megan, you started to touch on it with the fluid management.
Yeah.
I haven't heard you guys mention pressors much, or are we not seeing, sepsis needing pressors as much? I know you mentioned running them pretty dry, not even using any maintenance fluids. Can you just talk a little bit more about that?
Sure. We are, trying to, there are no maintenance fluids. We're trying to keep drips really to a minimum. So our goal in general has been whatever they're getting for their carrier, which we're trying to limit to 10 cc's an hour, and then their sedation drips is really all the fluid that we're giving them, and then just trying to do very sort of cautious, small boluses, often of 5% albumin. We are seeing in some of the, like I think I mentioned earlier, there really seem to be sort of two groups of patients, and one of them are the ones that we think are having kind of the cytokine storm, and the ones that are being evaluated for the IL-6 inhibitors. And they can come in profoundly hypotensive. We are using norepi as our first line vasopressor, and then vasopressin if we need a second one. And we certainly have some patients who have required pretty significant vasopressor support. Often we'll just keep a little low dose norepi on as we're trying to diurese if we think that they're fluid overloaded. Often some of the patients that are coming from the outside hospitals, which is the majority of our patients, do come fluid overloaded, and we are trying to diurese them pretty aggressively if they're already in acute renal failure, and certainly trying to keep them much more on the drier side. Our initial sedation plan, really coming from the adult side, is propofol and fentanyl. And as Dr. Gadepalli mentioned, because of all of the calories in the propofol, they don't actually need that much tube feed. Some of our patients, their goal tube feed rate is 15 cc's an hour of the Nutrin 1.5. Because of the fluid restriction, we are seeing a lot of hypernatremia. So we're doing some free water, primarily enterally, again, just to try and decrease as much of the IV ins as we can. So for sedation, we're trying propofol, fentanyl. We have started running into a little bit of an issue with some fentanyl shortages here. So this past week, I've been trying to switch over to more enteral. So enteral oxycodone and enteral Ativan, also to try and give a little bit more steady state. But one of the things that there's so many sort of little pearls about how to manage these patients in an ICU. And he mentioned it a little bit. Our protocol had been to do spontaneous breathing trials every morning at 5 o'clock in the morning. Well, in a 50-bed unit with 2 people in each room, it's hard to do that many SBTs. And we were having a lot of unplanned extubations very early in the morning. And we are using much more physical restraints than we typically do. But the big issue is, the patient starts reaching for their ET tube. I mean, it takes the nurse 5 minutes to get appropriate PPE on to go in the room. And in that time, we were having sort of too many extubations. So we're keeping patients more sedated than we would typically. And we're having to be a little bit more thoughtful about who gets SBTs and making sure that we just have the sort of the safety mechanisms in place. Communication from outside the room to inside the room is a challenge. In the 2 units in the children's hospital, the door is next to sort of windows, and so dry erase markers and writing on windows to communicate back and forth. We've used the phones already in the rooms, and we've put the phone number on the door. So if you're outside and the nurse is inside, you can actually call and use the phone in the room. We've also gotten a fair number of iPhones, and one stays outside the room, one stays inside the room, so that you can communicate back and forth, so you're not sort of opening the door and yelling in. There's still a fair amount of that going on. But it's all of these sort of little things that you don't necessarily think about until you're in the situation. And then one other thing that I think has been really helpful is, communication with families is always super important. And I think it's even more important now that the families, and I think this is probably true across the country, aren't allowed to be in the hospital and aren't allowed to be at the bedside. And so in a unit of 50 patients of very high acuity, how do you maintain adequate communication with families? And different teams are doing it in different ways. On some of the teams, it's the attending who after rounds just sits down and calls every family to give them an update. On my team this past week, we actually took an anesthesia resident who I think was on the pain rotation, which isn't doing very much. And his sole job was to come in, be there on rounds, and then he sat down and he called every single family and gave them the update. So I think also making a plan for who's going to communicate with families. In our 50-bed unit, we have 3 on-site social workers, and we have our own palliative care team for that unit. They're also going to expand over to the sister unit and cover. So things like, social workers, palliative care, and who's going to be communicating with family and how to do that in an efficient way are also important things to consider, because there's such a higher need for those services than we have on a normal day-to-day basis. And so those are just a couple of the things that the way that we've worked around it. So if that can be helpful to people, so they're not reinventing the wheel and discovering, 2 days in, oh yeah, now we need to figure out who's going to call families, how we're going to communicate in the room, those sorts of things has been really interesting to see the workarounds.
A couple of other things about fluids. One is that how persistent their fevers are is really impressive. Like they'll be in the 102, 103 range for like days, constantly. Like they're getting Tylenol pretty much around the clock, doesn't matter, like just febrile. And so, we do, follow their ferritin levels, their CRPs, their procalcitonin. What we're usually finding is that their procalcitonin are actually on the lower side and their CRPs are elevated and their ferritins are really high. And they can be in the thousands. And so those are the ones that we're kind of looking at using IL-6 inhibitors for. But the fever makes it so that they get really dry. But this is also in a population that's like hypertension, diabetes, potential previous heart disease, potential previous MIs. Some of them have had stents. Some of them have had longer heart transplants. They may have AKI, chronic kidney disease. So like, I know it's been a while for pediatric surgeons for taking care of adults, but there's a list, and some of these medications I haven't heard of because they didn't exist when I took care of adults. And so it's been a learning curve in terms of learning them again and going, oh, that's an anticoagulant that's used at home now. Okay, that's interesting. And like, oh, okay, like before it was just, metoprolol, but now it's like 80 other heart meds that are used for, hypertension management. The endocrine service here has been amazing. They've just taken over the hyperglycemia management on all of the patients. They just said, we're going to own that. And they've taken over Lantus, sliding scale insulins, like they just manage the glucose. Like I don't even have to think about it or worry about it. We've tried to limit the number of glucose checks, because that involves having to go into the bedside. And so typically it's like, getting your blood gas, getting a glucose all at the same time, getting whatever labs you need at the same time. So it's just being very conscious about the time periods around when you actually need those things. We almost never do x-rays, like maybe at admission, and then like a week later you might get another x-ray. Like we get x-rays for like Doppler placements, and then it's done like when they arrive, you just line them up, get your x-ray, and then that's kind of their x-ray for the admission. And you're just trying to limit the number of like trips in. Proning takes work. Like you have to really practice that, just like donning and doffing. Like last night was kind of a slower night for us, and we had people from the adult side, the RICU unit, come over and kind of train some people in how to prone and how to do it. And we just had one of our members serve as like a volunteer to help, like, how to be prone, and it's, you're not just going to like be able to do it. You're taking providers who, one, don't work together normally, and two, don't necessarily do some of the same maneuvers. In terms of like lung management, it's been primarily like ARDS type stuff. So like in terms of fluid management, it's all how to keep them dry, but just perfused well enough.